हाँ सेटिंग वेटिंग कर लेते अच्छे से
ठीक है बेटा।
So welcome all of you.
So hello, good evening everyone.
Welcome all of you to this integrated MCQ discussion.
So with us, with me, I have Dr. Ankit Khandelwal sir. So sir will discuss anatomy and I will discuss surgery. So same like we have been following this series now. I took yesterday also, I took one series. So today we are going to integrate two important subjects. One is surgery and one is anatomy. So you know these are the two most critical associations which we have. A surgeon without anatomy again is a challenge, and anatomy without a skills of surgery again becomes very difficult for the dissection part. So sir, let us start this series.
Sure. So welcome all, and this is the first MCQ to all of you. Kindly listen carefully. Question goes: a 48-year-old woman had been scheduled for a cholecystectomy. During the operation, the scissors accidentally entered the tissues immediately posterior to the epiploic foramen. The surgical field was filled immediately by profuse bleeding. Which of the following vessels was the most likely source of bleeding? You have the options also, so you can write also in the comment box.
Yeah, you can type your answer in the comment box. So I hope you can understand this, and this is what is very important thing. Same thing happens in laparoscopic as well as open cholecystectomy. So sir will discuss this initial anatomy part, and then I will discuss the applied part of this.
I will form the base, and sir will form the beautiful magic over the base. So guys, the options, I guess you all can see the options. Option A was aorta, option B was IVC, C was portal vein, and D option was the right renal artery. So let's start the discussion. See, the basic point over here is that if you look at the question, then the basic thing over here is they are saying that the surgeon has accidentally entered posterior to the epiploic foramen, right? Anterior entered posterior, and there was bleeding. So the question over here, the anatomical part is that do we know the boundaries of epiploic foramen, or what we normally call it as the foramen of Winslow? That's the basic question. So if you know the boundaries of it, then also you should know that what is lying behind it, and that should be a vessel, and that should be one that is causing the bleeding. So let us discuss over here basic anatomy about the epiploic foramen and what are the boundaries of it. So let's start a brief discussion of it, then I'll show you a couple of images as well. See, what we all know is that we have this esophagus, and we have the stomach, the lesser curvature, the greater curvature, and the duodenum, and the second, third, fourth parts. Here imagine we have retracted the liver, it's a huge organ, and imagine between the liver and the stomach with the first part duodenum, this is our double layered fold of peritoneum, which we all call as the lesser omentum, also known as your hepatogastric or the hepatoduodenal ligament. Also, you should be knowing that the right margin of the lesser omentum is the one which is slightly thickened, and inside it, what we have the portal tride structures, right? So where is epiploic foramen? All the space which you are seeing right now in front of whatever we have drawn, that is all is a greater sac, that is generalized peritoneal cavity. And the cavity behind the stomach, behind the lesser omentum, which you are not able to see, but you are able to perceive it, that one that is behind all of this, that would be our lesser sac, right? So the cavity behind this, that would be our lesser sac. Lesser sac will be behind this. Therefore, this point over here, this is the epiploic foramen, epiploic or the foramen of Winslow, which is connecting the greater sac to the lesser sac. And it's quite a good space. If you have ever gone to DH, your resident must have shown you and must have asked you to insert your index finger behind it so that you can understand the features of it. So this is epiploic foramen. Now, if you look at the boundaries of it, which was actually the question, the anatomic part, I will tell you the boundaries of the epiploic foramen. The boundaries of the epiploic foramen, what lies anteriorly is this right margin of lesser omentum. Here you have the portal tride structures. Now, needless to say in detail, we all know vein, portal vein, hepatic artery, and the bile duct. What lies superior to the epiploic foramen is a part of liver. Normally, we have the caudate process of the liver. What lies inferiorly is the first part of duodenum, because it is from here we have the starting of first part duodenum. So inferiorly lies the first part of duodenum. Now the question there was a bleeding from posterior. So what will lie posterior? Think about it. What is lying behind it? It's a peritoneum, but will peritoneum bleed? Not much. So there should be a structure which is retroperitoneal and a big vessel, and that too onto the right of midline. Apply the common sense, and we all know that is our IVC, inferior vena cava, and that will groove the posterior part of the liver where the hepatic veins normally drain into it. So if we only apply the common sense, even then you can rule out the options that okay, aorta is to the left side, you can rule it out, right? Portal vein also, but it is lying anteriorly, you can rule it out. The right renal artery, okay, but that is slightly inferior. So we have the answer over here as the IVC, that is the anatomical part of it. I will just show you a couple of images. So cadaveric image, now look carefully over here. You are looking at imagine the anterolateral aspect. Which aspect? Anterolateral aspect. This is the liver which has been retracted. And here you can imagine this is a part of the stomach. This is the lesser omentum, and this is the right margin of lesser omentum. So I hope you can very well imagine what is this circle. This would be our epiploic foramen. This would be our epiploic foramen. So that's the location of epiploic foramen. So obviously what is behind is the peritoneum, but there should be a structure which is behind it, and it should be a big vessel. That was the IVC. This would be a location of IVC, and that would be a location of portal vein, or we can say the hepatic artery. Just one more figure over here to let you understand the boundaries. This again, you can say a transverse section, and here's the anterior part, there is a posterior part. Already labeled as epiforamen of Winslow or the epiploic foramen, right? So you can see the anterior aspects of portal tride, and behind what you are seeing is the IVC. But tomorrow they can ask you a new question, what is the vertebral level? Go with the T12. That would be a new question, what is the vertebral level? Because on the CT and all images, they may ask you, okay, at which vertebral level you will be able to see the Winslow. So remember, the vertebral level might also be asked. So that was the anatomical aspect. I will ask sir to kindly put some light.
Sir has already discussed the concept of anatomy. But since this question was related to cholecystectomy, I would take you to some important things that we will understand here. So some few important points we'll talk about the cholecystectomy. And with respect to your exams, you often get a question on the callots, hepatocystic triangle, and the dissection of posterior triangle of safety. Now anatomy people are out there, surgery people are there, will explore the controversy and will settle out what is cholecystohepatic, what is the callots. Let us talk about that. Whenever we talk about the safe cholecystectomy, it is very important to understand that we need to respect the natural contours and the natural boundaries. Now, when you talk about cholecystectomy, you need to think that I should be restricting myself only to the gallbladder and its structures. Majority of the time, the right posterolateral duct is lying in front and it is accidentally injured. So what is the most important thing that you talk about? Answer is dissection of posterior window of safety. Now this is what is very, very, very important. When we talk about posterior window of safety, what do you mean by this posterior window of safety? Now, you should understand that this is nothing but opening up the cholecystohepatic triangle. Now, what is this cholecystohepatic triangle? This is nothing but this is the, you can say, liver. Then you have this is the bile duct. So this part of bile duct is known as common hepatic duct. I hope you know this. And then when it is a CBD, it is nothing but a confluence of the cystic duct with the common hepatic duct turning, and this is the gallbladder. So the first thing that we should understand is opening up this posterior space, and this space which is known as posterior window of safety, this is what is classically known as cholecystohepatic triangle. Now there was a lot of controversy that, okay sir, this is what we consider as callots. No, this is not callots. Actually, truly speaking, this is not callots. Remember, the first thing is posterior window of safety. What is callots here? You need to understand that there is cystic artery coming from the hepatic artery. Are you getting? So there are a lot of variations to that we'll discuss separately. So this is suppose right and the left trunk. So this is how the cystic artery is there. Now can you see a triangle which is bounded by cystic artery, cystic duct? Cystic artery, cystic duct, and common. So common hepatic duct. So this is common hepatic duct. This is cystic artery, and this is cystic duct, and this is actually the callots triangle. So remember, if we talk about what is callots versus what is cholecystohepatic triangle, you need to understand a broader perspective that this is the gallbladder, this is the liver, and this is cholecystohepatic, and inside this cholecystohepatic triangle we have a callots. I hope, sir, this is what is the update that anatomy books are also giving.
Exactly.
That callots that you used to consider it as a cholecystohepatic triangle is not at all callots. So if you dissect the posterior window of safety, the advantage is that you have retracted the gallbladder outwards, and now you can damage anything but not the hepatic structure. So this is one very, very, very important point. Now in this question, since we have seen and we have talked about the injury and a dangerous injury to the epiploic foramen. Now this is also, you can say, a blessing for us. The epiploic foramen is blessing for us, because in context with this, just see this image. This is where you can insert your index finger, Saras told you, or in laparoscopy we can index the, we can insert the forceps. So you can use the DeBakey's, etc. So I'm going to talk something about the concept of Pringle's maneuver. So what is the concept of Pringle's? Now this is what is very, very, very important. During cholecystectomy, many a times there is bleeding from the, you can say, cystic trunk, or there may be injury to the hepatic artery, there may be injury to the portal vein. So now what will happen? If you are doing laparoscopic, then you will actually start worrying. Why? Because you cannot have a quick vascular control. But yes, instead of buzzing the areas with the diathermy, you should try to go to the main window, and that is what is the epiploic foramen or foramen of Winslow. So when you talk about this foramen of Winslow, the concept is simply, it's very, very, very simple. So this is, suppose this is liver, and this is the bile duct, and then you have the portal vein like this, and suppose you have the hepatic artery like this. Okay, so what we can do, this is where the foramen of Winslow is. So you can simply take your forceps and you can clamp this space. So when you clamp this space, actually you cause occlusion of what, students? Occlusion of the portal structures. This is what is very, very, very important. Now let us talk about, this is also useful in case of liver bleeds. So when we talk about liver bleed, what is this Pringles doing in this case? Basically for cholecystectomy we don't require a Pringles. It is during the liver bleeds where we actually require the Pringles. So what could be the source of this liver bleed? Students, there could be three sources: hepatic artery, portal vein, and hepatic vein. Apart from this, there are no other sources. I hope bile duct will not bleed that profusely. So remember, out of these structures, you have occluded two important structures. What are that? Portal vein and hepatic artery you have just occluded here. So try to understand, whenever you have a liver bleed, perform the Pringle, and post Pringle check whether there is bleeding present or no. If the bleeding persists, that means that the bleeding was from the hepatic vein, and ligate that side hepatic vein. You know, you have three hepatic vein: main, that is middle, right and left. So remember, you can ligate it, and there is lot of collateralization that develops, and you don't have to worry about that. So hepatic vein is quickly ligated there, the side. Now if the bleeding actually continues, now you have to understand that either it could be from the hepatic artery or from the portal vein. Now this time you will release one of the structures, and you will see, suppose if I am clamping the portal vein, I will release the hepatic artery. If the bleeding doesn't happen, that means it is the portal vein which is injured. Suppose if I release the hepatic artery and keep the portal vein clamped, and after releasing the bleeding starts, that means hepatic artery is culprit. So continues, then you will have to check whether it is hepatic artery. If it is hepatic artery, it is jolly well ligated, because it is only giving 20% blood supply. When we talk about portal vein, you cannot ligate portal vein, it is always repaired. So remember, it is always repaired, and when we talk about repair, it is always repaired over a stent, and this is important for you. What is the suture of choice? We always prefer a Prolene. For 50 to 60 is what is the polypropylene suture of choice. Sir, these are the important things, students, that you need to understand with respect to this question and integration, how we can do with this question. So I hope we can move to the next question, sir.
Sure, sir.
Okay.
I guess sir explained beautifully, and this is the reason, not just the question, but the way the sir inspires for you guys to become a surgeon. Because these things, if they sound so beautiful to the ears, imagine how beautiful they will
but
be
actually
in the
it's a challenge also. God forbid if something happens, a vascular injury like IVC. I was just thinking when I was reading the question, injuring IVC means majority of the time the patient will not give you that much of time on the table. So majority of the time the vascular surgeons are not there, and nowadays the residents are not trained enough to do this IVC repair. And if they don't have the facilities in their center, the patient will collapse. So this is a big problem when knowing the anatomy and correct anatomy is the must know thing for, you can say, the surgery residents and the upcoming surgeons. And that is why in medical colleges in surgery especially, the professors are very strict. We feel like they're not giving us a chance to cut. This is what is the misconcept that we have. Remember, they also have a responsibility. The body is there, and in surgery the minimum and the maximum that can happen is death. So this is why we are very sincere. Let us go to the next
with
question.
great power comes great responsibilities. Chali, let's see next question. So there's another beautiful question for you guys. Listen carefully. That which of the following anatomical relationships would be seen clearly on exploratory laparoscopy without dissection when the surgeon exposes the beginning of jejunum? So it's a complete integration question. So what you are going to see once you reach the beginning of jejunum? Options over here are: the second portion of the duodenum is related anteriorly to the hilum of right kidney, or the superior mesenteric artery and vein pass posterior to the third part of the duodenum. The port vein crosses anterior to the neck of the pancreas, or the second part duodenum is crossed anteriorly by the attachment of the transverse mesocolon. Now see here, you can apply the common sense. First of all, see that all the four options right or not. If there is any wrong option, omit it. Then see what the options are left. What you will see when you reach the beginning of jejunum. For that you need to know jejunum, ileum. They are small intestine, they are intraperitoneal. So once you open up the abdomen, you reflect the greater omentum. What you see is the small intestine. So there, if you go proximally, you reach the jejunum. Now what you are going to see, it's a totally practical question. So if you look at the options, I'm sure that you will be able to rule out the options which are not correct. For example, second option, the superior mesenteric vessels pass posterior to the third part. Now you all know that they pass anterior. There is a SMA syndrome, the nutcracker syndrome. So you can omit this option. You don't know the answer, but you're just omitting out or omitting out the other ones. The portal vein crosses anterior to the neck of pancreas. Now that's a landmark. We all know that the portal vein is formed behind the neck of pancreas. So remove this option as well, right? Now we are left with options A and D. The second portion of duodenum is related anterior to the hilum of right kidney. Is the statement correct? What do you think? Statement is totally correct. Yes, it is correct. Can it be the answer? Let's see. But see, we have reached the jejunum. You have reflected the greater omentum. You have reached the jejunum. Jejunum is intraperitoneal. And what is duodenum and kidney? Both are retroperitoneal. It's like both are, when you are sleeping with a blanket over you, you are the duodenum and the kidney. You are behind the blanket. So will you be able to see it? Who is sleeping behind the blanket? Obviously not. Therefore, the duodenum and kidney are there, but you will not be able to see them clearly. So they are actually lying posteriorly. Let's see the last option. The second part duodenum is crossed anteriorly by the attachment of the transverse mesocolon. Now this transverse mesocolon, we all should know, it is attaching the transverse colon, and there is a whole transverse mesocolon, and the root is attached in front of the second duodenum and the pancreas. It goes actually from nearly the lower pole of the right to the lower pole of the left kidney. That is the approximate location. So will you be able to see it? Obviously, yes, you will be able to see it, because this is connecting to an intraperitoneal structure, which is transverse colon. And it is quite anterior. If you remember, if you just add a little bit of embryo over here as well, the rotation of midgut, that is a 270 degree, then you know why the transverse colon is coming anterior and why duodenum is pushed posteriorly. So taking all of these little bit of knowledge, little bit of common sense will reach us the answer that option D would be the correct answer over here. And let's see if we had an image over here. This simple image for you guys to look at the relations. The simple image, this is the duodenum, what you are seeing, the first part, the second, the third, and the small fourth part. Just focus, these are the anterior relations of duodenum. So look at the anterior relations, you can see the superior mesenteric vessels crossing in front of third part of duodenum, right? Why it is crossing in front? It has to go inside the mesentery, common sense. Now here is the attachment of the transverse mesocolon. This is attached somewhat like this. So therefore anatomically also, there may be a new question that the duodenum and the upper part of duodenum, that is the first and the upper proximal half of the second part duodenum, is in supracholic compartment, and the lower part of duodenum is in the infracholic compartment. That can be another small question. But look at the scene over here. Here the jejunum will start. So once you have reached over here, you will see the attachment of transverse mesocolon. These are the anterior relations. Here you can see the liver and gallbladder that we were discussing. So remember that gallbladder stones might also at rare times might come to duodenum, and there is a pneumobilia, and all those questions have come. So simply looking at the relations and simply applying a common sense, I hope you can reach the answer, and the surgery part, I guess sir will explain us beautifully, and I'm waiting for it.
So students, whenever we do a diagnostic laparoscopy or maybe an exploratory laparoscopy for some pathology, so the first thing that we need to understand that until and unless, like sir, the question says, it's very simple. What will you look inside? You're looking at the DJ flexure maybe. So you are at the first part of the jejunum. So now from the first part you can trace all the jejunum and the ileum. This is one thing visible. Then what will be visible? Colon will be visible. Students, until unless you do cauterization, that is mobilization of duodenum, how can you see the kidney? So this part is not going to be visible to us. Again, all the structures that you are seeing, they are retroperitoneal. So question is very easy, but actually this question comes with a lot of things that I have planned for you. So when I am talking about cauterization and this peritoneal mobilizations, they are very important. Every exam you are having some questions on this. So let us try to understand that it is just like two different flats or two different home with a partition in between. So my flat is my home is my, someone else's home is someone else's. So you cannot transpass that until unless you have some maneuvers. So try to understand that this is colon. This is what is very important for you to understand. So this is the colon and this is how the stomach is, and peritoneal cavity is totally separated from the retroperitoneal cavity with these all peritoneal folds. So everywhere you are having the peritoneal folds. I hope you know, all of you know, should be knowing this, and here you have spleen. So everywhere you have peritoneal folds, that means nothing from the peritoneal cavity can go into the retroperitoneal cavity. So suppose I want to do right hemicolectomy, I have to mobilize the right side of the colon, then I can do. So what are these peritoneal folds known as? These peritoneal folds, we call them as white line of Tolts, and this is what is very important. Until and unless we mobilize this white line of Tolts, you cannot go into the retroperitoneal space. So what are the questions that we get? So suppose if I want to mobilize the colon, I will have to cut the white line of Tolt on the right side if I want to do a right hemicolectomy. Same, if I want to go on the left, I will have to go to the left side and dissect this. So what are the terms that we have for them? So I have shown you 3 peritoneal mobilizations, and let us have the terms for them. So what are the terms for A? So peritoneal mobilization around the duodenum. What is that known as? Come on students, tell me. So peritoneal mobilization around the duodenum, this is what I have already told you. Around the duodenum, this is known as cauterization. Many a times this question has been asked. This is what is known as cauterization. Same thing. Now there are 2 twists. Peritoneal mobilization around the right colon, this is what is known as Cattle-Brash maneuver. This is what is known as Cattle-Brash maneuver. Students, now this is how the confusion creates. Let me tell you, they always give you something that is going to confuse. They say left medial rotation of the viscera. Remember, that's the same thing. So left, I am rotating this viscera on the left side. So instead of writing the peritoneal mobilization on the right, they say left medial rotation of the viscera from, what is this? That is what is Cattle-Brash. And same thing if I do it for the right side. So right visceral medial rotation, and or you can say division of white line of Tolt along the left side. What is that known as, students? That is known as Mattox maneuver, and this is what is very important thing. So these are the first 3 things that we can get to understand from this basic dissection. Then students, I will just pick up, because surgery and anatomy both are vast, we can enter into any space, but try to understand something about the superior mesenteric artery and vein. Sir has already told you about the relations, so try to understand what is this aortomesenteric angle. Now this is what is very important. INI-CET, I think if you check the 5 years question, you have got lot of question on SMA syndrome. They have talked about lot of things. So when we talk about the SMA syndrome, it all depends on one very important thing, that is, now this is the relation. So this is the aorta and this is what, student? SMA, and this angle is known as aortomesenteric angle. So we have something which is known as aortomesenteric angle that can range anywhere from 36 degree or 38 degree to 54 degree, 56 degree, the lot of things. Average we take it as 45 degrees, average, let us take it. Students, in between that we have the duodenum, and do you know, normally this duodenum is not crushed. Why? Because we have a pad of fat protecting it, and this is why anorexia nervosa, rapid weight loss, and these conditions are especially seen in females. So rapid weight loss, J-shaped colorectal anastomosis that we make. So you can say prolonged immobilization. This is also known as cast syndrome. When we actually apply a cast, what will happen? There will be pressure atrophy of the fat. So the moment there is loss of fat, what will happen? There will be decrease in angle, and decrease in angle to less than 25 degrees centigrade, to centigrade I'm saying, 25 degree will start with the features of, you can say, compression, and this is what is very important. So what is this known as? This is known as SMA syndrome. Why SMA syndrome is very important for you to diagnose? Because SMA syndrome is not a first line, you can say, surgical thing to be managed. Majority of the patients are counseled, you monitor the nutrition and they will manage themselves. Now, if the treatment of choice when we talk about is first line is conservative, treat the conditions which are associated. If it fails, then what to do? In that case, this is how the duodenum is. So you'll have to go for duodenostomy. So we go for don't resect the, we cannot resect SMA or SMB. So duodenostomy. These are the two things that we need to remember. Discussing a lot of things is beyond the scope of this, you can say, session. It's a very small integrated session. So I'm just trying to discuss a lot of things that I can for this. Now, you know this portal vein crosses where to the pancreas, posterior to the pancreas. What is the significance of this? Answer is triangle of love. So remember, whenever I want to dissect a pancreas and whenever I am going for pancreatic surgery, the first thing is I need to resect, I need to check the resectability. And when we talk about the resectability, we have a Vardachari-Kratz criteria. Remember, when we talk about Vardachari and Kratz criteria, we take a look at 4 important structures. What are they? Common hepatic artery, celiac trunk, superior mesenteric artery, and junction of portal vein with the SMV. Remember, junction of portal vein with SMV. Why it is important? Because merely portal vein involvement is not an important thing, because we can do, you know, you must have seen Fortner's surgery where we can do a resection, segmental resection of the portal vein. The problem is, it is the junction of portal vein with the SMV. Why? Because if this tunnel of love cannot be, you can say, dissected, the retropancreatic window cannot be done, and if that is not done, it is not possible to lift up the pancreas and resect the head. So these are some important things that we need to understand. Now, when we are talking about the second part of duodenum with respect to mesocolon, sir was telling you about this orientation, students, and the concept of rotation and malrotation. Now, what I am going to add to this is, now you are seeing colon in front of you. So this is what is colon. How I can integrate something important is, like, this is how the jejunum is arising. Rest everything is retroperitoneal. So I am having a peritoneal cavity view. Students, one of a very important surgery, very common surgery is the gastrojejunostomy. So when you are doing a gastrojejunostomy, so what is the next thing that you have to do? Maybe you are doing a loop gastrojejunostomy, or maybe you are doing, suppose this is gastrectomy has been done and you want to do a Roux-en-Y gastrojejunostomy. So the orientation, how you are taking it, will decide whether this is anticolic or retrocolic. So when you take it anterior to the, this colon, so suppose if you get a view, like this, so suppose this is what is the view. So that means you have taken the jejunum anterior. So this is what view? Anticolic. The advantage is that you don't have the risk of internal hernias, because when we talk about internal hernias, what is that? We make a gap or a window in the mesentery and take it through the avascular window. So if the same thing, if I do, suppose this is the gastrectomy site. Now this is the, you can say, this is the transverse colon, and if I make a window in this, and then if I take the jejunum, or suppose I want to do a Roux-en-Y gastrojejunostomy. So if I do a gastrojejunostomy like this, what is this, students? Retrocolic. But the advantage that we get is the shorter length of limb is wasted here. Here, relatively longer limb. But the disadvantage is that anything can go inside, causing what? A Stemmer's or a different type of Peterson's hernia or a transmesogastric hernia. So the transmesocolic hernia, there are a lot of things that we need to understand. So these are some important things which I decided to discuss with this. Shall we move to next question, sir?
Sure, sir.
Okay.
Okay, guys. So come back to the next question. I guess all the things are clear. So here's a question on the insulinoma, pancreatic insulinoma. So there's a patient with a pancreatic insulinoma and is being prepared for a lap enucleation of the tumor. After induction of the GA, the preparation of the sterile surgical field and port placement, the surgeon needs to enter the space posterior to the stomach to access the pancreatic tumor. Which of the following ligaments must be cut in order to access this space? Again, as you are looking at, all these questions are about relations, about the actual OT scenario, about the clinical aspect. And these were the questions, if you remember, if you take the last 4-5 years or maybe more than that, most of the questions are now coming from here only. When I guess Sir will also agree on me, and when we used to give PG exams, it was single line questions.
Yeah.
It was single line questions, most of them are repeated questions. So now things have changed and things change for good, I suppose. So here again, you're seeing the problem is lying in the pancreas, it's the insulinoma, and you have to reach there, right? You know where the problem is, you have to reach there. Now they're asking you that it's posterior to the stomach. Obviously stomach is intraperitoneal and the pancreas is retroperitoneal. If you go to a little bit of basics, it come in the stomach bed. Pancreas comes as a stomach bed. Now they're asking you, okay fine, this pancreas stomach bed, but tell me the ligament. Options are phrenoesophageal ligament. Phreno is, we all know, diaphragm, and esophagus. What do you think? Would you like it? Would you cut this, or hepatogastric ligament, which we are discussing right now a few minutes back about the lesser omentum. So lesser omentum, it is hepatogastric plus hepatoduodenal. Third option is phrenicocolic. So it was again asked a couple of years back. Remember the spleen question? The spleen is not able to go down directly, something like that, when there is splenomegaly. Why it is going towards umbilicus? That was the question. So remember all these options. Phrenicocolic, it's from diaphragm to the splenic flexure of colon. That's also important ligament. And there's a falcium ligament from liver going anteriorly into the anti-abdominal wall, having the ligamentum teres at its lower margin. These are the options. Now the thing over here is, you know what is the goal. Goal is to reach pancreas. Now what route you have to take? That is the question over here, and that is the beauty of surgeons, which they do. So guys, what do you think? What is the answer? And any comments in the comment box if you
Yes,
want
students,
to go?
do comment on this. This is a very good question.
Think.
Easy question for you people. You need to understand that where is pancreas? It is behind the stomach. So you need to enter. And the question is very easy. You have two windows here. Either you can go from the splenic side or you can enter from the liver side. So these are the two windows that are explainable here. Obviously, phrenoesophageal ligament is not important here. It is important if we do the fundoplication surgeries, if we do the, you can say hiatal hernia, hiatal surgeries, and then falciform ligament has no use here. So try to understand. It's a very easy question. We'll go for hepatogastric ligament. This is what is very important. Sir will tell you some relations and then I will tell you some important points related to this.
So I guess till now you got the point that why hepatogastric ligament is the answer, because as we have seen that, let me just try to make something over here, that we have this, imagine lesser and the greater curvature of stomach, right? And this is imagine the duodenum going. Now, the duodenum and all, they are actually lying retroperitoneal, right? Imagine that's a peritoneum coming over here. Everything is lying retro. Now here was the ligament, your lesser omentum. Imagine it's going like this, lesser omentum. Where is the pancreas? Pancreas is where you all know that in the concavity of the duodenum, there is this head of pancreas, right? And it will go like this. And imagine the spleen is over here. That's the location of spleen. And you should know that the tail of pancreas is entering into the hilum of the spleen. So therefore, the pancreas, you know that it is from here to here, and uncinate process also, it's going like this. That's the pancreas. So pancreas lying behind the stomach, and there's insulinoma, and you have to reach the pancreas. So obviously, you have to reach somewhere behind the stomach, and therefore this is one ligament that I can write as HG for hepatogastric. Other options are phrenicoesophageal, so it will somewhat lying somewhat over here, but that is, as Sir told, about the hiatal hernias and the fundoplication. The phrenicocholic will be actually from this, imagine the colon over here, and this will be the phrenicocholic ligament. So if to mobilize the colon and all, obviously you need to cut it, or you have to mobilize the spleen and all. And the other options are falciform, as Sir told you, that once you open the abdomen, that what you see is the falciform ligament. So therefore, the answer over here was our simple hepatogastric ligament, because that is the one by which it is lying, you will reach behind the stomach. And what's the cavity behind the stomach? The cavity behind the stomach is lesser sac. So remember the topic of surgeries also, which we used to read, the pseudocyst of pancreas. Where does it lie? This pancreas inflammation, the cyst is lying in the lesser sac. So therefore, if you reach the lesser sac, you have reached the pancreas, because just lying behind the lesser sac is the pancreas. So this question, see, abdomen is all about understanding where are the organs. If you have a general idea of it, then obviously you can add the surgery over it. So the base needs to be clear.
Students, here if you see, like, less knowledge is good, but more knowledge is a lot more confusing. You know more, you get confused more. So let me tell you, if you ask me at my level, there are a lot of things in this question. Let me tell you why. Because when we are talking about the anatomy part, one very important thing is that this is the stomach that we have, and then you are dealing with the pancreas. So here you are having the pancreas. Now what are the important things that we need to understand here? That there are a lot of ligamentous structures, but in front, what is present here? What is present? It is transverse mesocolon. Students, this is what is very important. So what is present here? It is the transverse colon. And when we are talking about this, and this is a pancreas which is enjoying a window where no one can enter inside conventionally. And then we have a lot of structures here. So what is this? This is gastrocolic. So you need to cut the gastrocolic. Why? Because until and unless you don't divide the gastrocolic, you will not be able to access this part. Second is that you have the pars flaccida or hepatogastric. You will have to divide this hepatogastric also, because this is again very, very, very important. Then students, you have the, you can say, gastrosplenic ligament, splenocolic ligament, and until and unless you cut even the epiphrenicocholic ligament, you will not be able to mobilize the pancreas. So ideally, if you see in this question, it should be like which is not actually mobilized. So the answer would have been falciform ligament. Falciform ligament, we generally don't have to do anything. What are the structures that we can mobilize? Hepatogastric also, because this question is not telling you that whether or no it is in the tail. But you still have to create that window, be it in the body, be it in the tail. You will have to explore the pancreas. So even the you can say this is the gastrocolic, that also you have to mobilize this colon, splenic flexure of the colon. You will have to do this mobilization also. You will have to do the mobilization of gastrosplenic and splenocolic. So at least if you talk about this question, I would say the question would have been which is not mobilized. But since a very, very, very interesting question, this question, these type of questions are asked where lot of things are there. So hepatogastric would have been the best option, because this is where you actually directly go into the retrogastric space. So remember, this is one important thing. Now let us discuss something about insulinoma. So when we are talking about insulinoma, one very important thing is that what is insulinoma? This is a neuroendocrine tumor of the pancreas. And what cells of pancreas are involved? Answer is beta cells. It's a tumor of beta cells. Now 2-3 important points that you need to remember on insulinoma, that since it's a beta cell tumor, there will be increase in insulin and lot of problem arises because of this. It's a benign tumor. We know it's a benign tumor. What else is the average size? The average size is less than 2. It's a hypervascular tumor. It's again a hyper. These all points are very important because we will see them when we are following the management. And then it is encapsulated. So these are the 5 important features. When we talk about the clinical presentation, you know the classical Whipple stride. I hope students will answer this. Come on, tell me what are the features of Whipple stride. So the first is the attack of hypoglycemia. So you will have attack of hypoglycemia. The second thing is the blood glucose actually go abnormally low, and they go up to the level of less than 45 mg per dl. This is what is very important. And then the correction of symptoms, on administration of exogenous glucose. This is what is very important. This is what is classically Whipple stride. Apart from this, since you have multiple hypoglycemic attack, you will have high affinity for having high glycemic index food, and thus you will be overweight. So overweight, obesity, and then chronic hypoglycemia makes these patient cerebrocytes go starve, and that is why they have lot of neuropsychiatric complications also, like apathy, emotional disturbances. These are classical things. Now what is the investigation of choice, students? Since it's a neuroendocrine tumor, it has to be biochemical evaluation, and therefore we have 72 hours fasting glucose levels. Do you know what do you mean by 72 hours fasting glucose levels? You will admit the patient, start the patient on fluids, but not on DNS, and you will go for what? NPO status. So 72-hour fasting glucose levels abnormally less than 50 mg per dl in case of males, and less than 40 mg per dl in case of females. This is actually what, students? This is actually diagnostic, and this is what is very, very, very important. Apart from this, you will see that there is increase in C-peptide levels also. Then there is pre-proinsulin, proinsulin. So pre-proinsulin, proinsulin, everything will be elevated. Now why it is? Because it is actually a tumor from the beta cells. Now many of the time, if you take exogenous insulin in a high dose, you'll have the same things, but proinsulin C-peptide levels will not be elevated. Now you will say, sir, if it is a sulfonylurea toxicity, I've taken excess of drugs, what will happen? We'll have the same stimulation excess beta cell stimulation releasing insulin. So in that case, you will have C-peptide, pre-insulin, pro-insulin levels also elevated. In that case, check the urine for drug levels, and that you will see that the urine drug levels are elevated in sulfonylurea toxicity, and there is no such thing to be documented in case of insulinoma. The treatment of choice for them is enucleation. Why enucleation, students? This is very important. Enucleation helps you to remove the benign part of the tumor. So enucleation is what is the treatment of choice. Now the problem is if it is located in the tail. So this is the pancreatic anatomy, and suppose there is a tumor located in tail. So many people say, sir, for the tail of the pancreas we'll go for distal pancreatectomy. No, not at all. The answer is, if it is superficial along the tail, then you can go for enucleation. Remember, if it is, you can say, deep into the tail, the moment you go for new enucleation, you will slough of the pancreatic duct. And that is why for deep tumors, you will have to go for distal pancreatectomy, and this is what is very important. So I think this is all for this question, and I hope you, this is again an image which sir has brought, and I have discussed that very same image. So now let us go to the next question, sir.
Sure. So let's see the next one. A 43-year-old lady came with a large abscess in the middle of the right posterior triangle of the neck. The physician incised and drained the abscess. 5 days later, the patient noticed that she could not extend her right hand above her head to brush her hairs. What could be the cause? Right. So after 5 days, she is not able to simply brush her hairs. Options are damage to scalenus medius muscle. This could be a muscle problem and it's not able to. Okay, let's see. Injury to suprascapular nerve. Now you have to think that there can be injury to it if you are thinking about it, but what muscles does it supply? Will it lead to that? So think about it. Or cut to the spinal part of accessory nerve. Remember the location of the nerve and what it supplies. Will it help in those movements? And last is spread of infection to the shoulder joint. So they're asking for secondary, you can say, pyogenic arthritis to the shoulder joint. So what do you think is the answer over here? I mean, it's a very repeated question. This sort of question, they have started asking it around 10-15 years back, these sort of questions. I remember when I gave the AIMS exam, AIMS PG exam, this was one of the questions that came for the first time at that. But yeah, after a few years, they are repeating it again and again. So guys, the answer over here is what? The anatomical part, we can say that the question is talking about the anatomy around the posterior triangle of the neck, that is the triangle of the neck. Now what is the posterior triangle? It is not exactly posterior, but in comparison to anterior region, it is slightly, you can say, posterolateral. So this triangle over here, we call it as a posterior triangle. The one that is lying posteriorly actually is what we call as a suboccipital triangle, right? The posterior triangle is over here, you can say it's a sort of lateral triangle. What is the structure over there that could lead to this problem? The answer over here is the structure is lying in the posterior triangle, that is our 11th accessory nerve, the spinal root of accessory nerve. That is the one structure that lies over here, and it is supplying these two muscles. Remember, we'll look at the anatomy of it, but I'm just telling you how to rule out the other options. See, scalenus medius, it can be injured or not, it's lying very deep first of all. If it is injured, it is not helping in this overhead abduction. Remember, the movement is OHA, which is not your oral hypoglycemic agent, it is overhead abduction over here. So the scalenus medius has not much role in overhead abduction. So even if that is injured, though that is not, but that could not be the answer. The suprascapular nerve, it runs over the upper body of the scapula. It is coming from the brachial plexus. The muscles which it supply are supra and the infraspinatus. The supraspinatus helps in abduction. Absolutely correct, but not infra. But supraspinatus will only help in initiation of abduction. So when they are saying the patient is not able to raise the hand above the head, the patient will not able to move the upper limb. Though if the deltoid is intact, it won't be much of a problem. Try to link over the upper limb anatomy. But yeah, involving only supraspinatus has nothing to do with this. So though the suprascapular nerve is not injured, but even if it is injured, then also this won't be the correct one. Spread of infection to shoulder joint. Now there's a whole total history will change over here. This shoulder joint, there's a decrease in the range of movements. All those things will come. There's shoulder pain over here. They're only saying unable to raise the hand above the head. Now why is this the answer? Spinal part of accessory nerve. Because if you remember, then this nerve over here, the spinal root of accessory nerve, it is basically supplying two major muscles, which are your sternocleidomastoid and trapezius. These two muscles. So it is coming from where, if you just, I will let a little bit of course over here, that will help you understanding. It's coming from the jugular foramen, right? First, it is the only nerve which passes through two different foramens. This nerve enters into the cranial cavity and comes out of cranial cavity. How does it enter? It enters through the foramen magnum. If you remember, it's one of the contents of foramen magnum. Then it travels inside the cranial cavity and comes out through the jugular foramen, right? Jugular foramen. And then along with the 9th, 10th nerve will come out. And then the cranial root will go along with the vagus nerve, but spinal root will go behind. And that is why when as it is going behind, we say it is lying in the posterior triangle. And there it supplies both of these muscles. If you look over here, this is my sternocleidomastoid, and that's my trapezius, the collar muscle. This nerve is going like this. It is very close to the roof of posterior triangle. Now, as we have just repeated this term posterior triangle, triangle, let us look at the triangles of neck over here. So here is a lateral view. These are two muscles that we are referring over here. This one is the sternocleidomastoid, and that is the trapezius over here. So this triangle over here, this is the posterior triangle. And the posterior triangle, a bit of anatomy. It has a major part which is lying superiorly, and that is known as the occipital triangle. So this is occipital triangle over here. And a smaller part lying inferiorly, that is what is lying over here. First of all, the structure lying is a subclavian vessel, so we call it as a subclavian triangle. But then some says, no sir, it is supra. Yes, it is supra, but not supraclavian, it is supraclavicular. So both names are correct. Supraclavicular because anatomically lying above the clavicle, and subclavian because subclavian vessels lie over here. So it is supraclavicular triangle. Now coming back to the topic, this is the region where the axillary nerve will pass from SCM to trapezius. That's the point. So if you are doing any procedure over here, or there is a pancreatic injury over here, there is a lymph node biopsy from here, could be abscess over here, you can damage this nerve, can be damaged. Now if this nerve is damaged over here, suppose this nerve is damaged, which muscle will paralyze? Will the SCM or trapezius or both of them? Basic common sense that the proximal branches will be intact. So it's a distal one that will be hampered, and here therefore trapezius is the one which is affected. So what is trapezius doing in overhead abduction? Remember overhead abduction, there's a scapula has to move, scapula has to rotate, and therefore we need the trapezius. So in overhead abduction, remember always the two muscles mainly involved are trapezius and it's not a sternocleidomastoid, it's a serratus anterior over here. And also in trapezius, not the entire trapezius, mainly upper and lower fibers. So therefore, if the spinal axillary nerve is damaged over here, the trapezius innervation will be gone, and the trapezius is the important content or component for doing overhead abduction, supplying the moving the scapula. Therefore, obviously there will be weakness in it. Now the patient doesn't know. Patient can't relate because there was a surgery you did over here, and the limb is not moving. So patient might not even complain to you. But you have to see and you have to ask. If patient might complain, you have to correlate it. So that's the anatomy of the posterior triangle. Over here, the boundaries, remember, and these all are the anterior triangles. These all over here, these are the anterior triangles. Now remember, the triangle anatomy is very important because of the important contents. Now there are 3-4 things which you need to remember over here. Not 3-4, just 2 more. Because 2 we have seen is the sternocleidomastoid and the trapezius. Just remember 2 more muscles, just 2 more. One is the digastric over here, having the anterior and the posterior belly. And one is the omohyoid, superior and the inferior belly. If you remember these 4 muscles, all the boundaries of all the triangles are done. Simple. So just remember digastric having 2 bellies. So there is a hyoid bone over here. So it's the anterior belly of digastric, there is a posterior belly. And between them, which triangle is the digastric triangle already written over here? What is the name of digastric triangle? Feel the structure over here. What you can feel over here? There is a gland. Therefore, it's known as submandibular triangle. Location of submandibular gland. Also, it is lying below the mandible, so it is submandibular. The anterior triangles over here are further divided into this lying over here, where you can see the strap muscles overlying the larynx and the thyroid gland. This is the muscular triangle. Why muscular? Strap muscles. The sternohyoid, the sternothyroid, that is it. Then the one where you feel the carotid pulsations, carotid sheath over here. So the triangle is carotid triangle. Simple as that. What is left is this very small one, submental triangle. So there's a smaller one over here known as submental, where the mental symphysis over here. Just below this triangle is small one. And this is the only triangle, a new question can also come, which is unpaired. Meaning by all the triangles, we have a left carotid, we have a right carotid. We have left digastric, right digastric. But submental is only one. If you look over here, these are the 2 anterior bellies, that is the hyoid bone. We have only one submental triangle. So that can be a question, it is unpaired, remember it. So it's a basic anatomy of the triangles. And the most important structure lying in the posterior triangle is this root of accessory, because that is the one that is clinically important. Also, they may ask you that why it is known as occipital triangle? Bone is over here. Why we call it occipital? There is nothing occipital over here. The answer for that is there is an occipital artery that is going towards it, which is a branch of ECA, external carotid. So it is due to this artery we call it as the occipital triangle, because if you are inquisitive, the question should come to your mind that when you are reading something, okay, I have read it a lot, but why it is occipital triangle? That should come to your mind if you are reading for the first time. Remember these basic points. So that was the anatomical part of it. I will request sir to throw some surgical light for all of us.
So that was a very beautiful discussion, and students, it's very important for you that vessels are actually dominating these triangles. So majority of them are named upon the vessels they actually carry. So this is what is important, but for us, knowing this anatomy is the most important thing that we can do in relation to the lymph node dissections or the neck dissections. So here I decided to discuss something about the neck dissections. So students, what are the type of neck dissections that we have or that we can do? We have three classical type of neck dissections. The first was radical neck dissection. And what do you mean by radical neck dissection? Nothing but removal of level 1 to level 5. So you remove level 1 to 5 group of lymph nodes, and along with that, why it is radical? Let me tell you that there is resection of three important structures. What is that? The sternocleidomastoid muscle, along with that internal jugular vein, and along with that spinal accessory nerve. Now try to understand that if you talk about sternomastoid, I can understand that upper jugular, mid jugular and lower jugular levels are hindered by this. Yeah. So level 2, level 3, level 4 might be coming, so you may resect it. Okay, I understand. I even understand that internal jugular vein, okay, is coming in your vein. That is why you wanted a good dissection, you have ligated it. But what about spinal accessory nerve? You could have easily retracted it away, and that is why you see that typical frozen shoulder like condition basically. So trapezius is the culprit here. Spinal accessory nerve is the culprit here that is causing this thing, and sir has beautifully framed a question also on this, and that was the need that we have to modify the radical dissection. Apart from this, there was removal of submandibular gland also, and along with that there was the removal of tail of parotid also. All these structures were removed, and that is why it was known as too radical. So Kreil, who did this radical dissection, was over the time condemned, and it was Boca who decided to go for MRND, modified radical neck dissection. The classical modified neck dissection, everything is same, but actually they are going to preserve. So there was preservation of minimum, at least the classical that was done was the preservation of spinal accessory nerve. It was later that there was a you can say agreement done, or there was a conference held in Medina, and in Medina, according to this, we have Medina's classification for MRND, where we have type 1 MRND. In type 1 MRND, you dissect level 1 to 5, but this is on preservation. So if you go for preservation of spinal accessory nerve only, that's a type 1. When you talk about type 2, it's a preservation of spinal accessory nerve plus vein, internal jugular vein. And then type 3, where you go for all the structures, but they are removed, structures removed are same, but preservation of nerve, preservation of vein, internal jugular vein, and along with that spinal sternocleidomastoid is also preserved, and thus this is what is known as functional neck dissection. So what is a functional neck dissection? You remove all the lymph nodes L 1 to 5, but you preserve all the three structures, and then came the concept of selective neck dissection. So I will talk to you about selective neck dissection also. When we talk about selective neck dissection, we have SOHND. What is SOHND? Supraomohyoid neck dissection. So what are the levels removed here? Students, it is level 1, level 2, level 3. Then we have lateral neck dissection. What is the structure? What are the lymph nodes removed here? Level 2, level 3, level 4 are removed. Then we have posterolateral. So sir has discussed this. Along with this lateral, posterior part also. So level 2, level 3, level 4, and along with that level 5, and along with that posterior occipital also, and retroauricular lymph nodes. So these are the lymph nodes which are removed here. Then students, we have the central neck dissection. When we talk about central neck dissection, we remove only level 6. Just trying to summarize it up, but before that, I will also help you remember. This is how I remember what are the various lymph nodes, and then you can actually, sir has shown you a beautiful triangle based diagram, so I will just give you an easy way to remember lot of other things. So suppose this is the hyoid, okay. So these are the digastrics that we have, and then this is the mandible that we have, and this is the, you can say, this is the sternum that we have, and these are the clavicles that we have. So this is how I draw a simple diagram for you. Remember, these are the strap muscles in between. So this is what? Sternohyoid, sternothyroid we have. Okay, and this is the midline from the mentum. So this is mentum, this is posterior digastric, this is anterior digastric, and where are they going? This is the styloid process. So from here you also have one more muscle, that is stylohyoid. Okay, I am just trying to show you something. From here you have, this is what is sternocleidomastoid, and this is what is, here you have the trapezius. So what I wanted to tell you, one very important thing is the concept of the lymph nodes, and this is how you will learn a lot of things. Remember, sir has told you triangle, so this is level 1A, this is 1B. So submental, submandibular group of lymph nodes. Now at the level of hyoid, just see, at the level of hyoid, if we go imaginary line towards the sternocleidomastoid, this is level 2, and do you know this level 2 is further divided by the spinal accessory nerve also. So 2A and 2B. Then from the level of cricoid up to the level of sternocleidomastoid, this is what is known as mid-jugular or level 3, and then above is mid-jugular, above is level 3 and below is the clavicle, and in between them you have the level 4, and this is what is level 5, and this is level 6. So next time if I say what is the supraomohyoid, so here still we don't see the omohyoid, so this is the inferior belly and this is the superior belly of omohyoid. So just see students, you can understand this is level 2, this is level 3. So next time someone says what is supraomohyoid neck dissection, so answer is we are going to remove these lymph nodes, level 1, level 2, level 3. Try to understand where do you do supraomohyoid dissection for oral cancer. Now added question, what is extended SOHND? Extended SOHND, extended supraomohyoid neck dissection. Do you know that tongue cancers, they might have, like papillary cancers of the neck might have a skip metastasis to the lateral group without going, so that's a direct spread to the lateral part of the neck without going the lymphatic route. Same way the tongue cancers can directly go to the level 4, and that is why extended SOHND is done for CA tongue, where you go for level 1, level 2 and level 3 also, level 4 also. Someone says you, what is lateral neck dissection? Level 2, level 3, level 4. What is posterolateral? Level 2, level 3, level 4, and along with that level 5. What is central neck dissection? This is what. So remember this easy diagram, and this will make your life very, very, very easy. So students, now we will go to the next question. I hope we can go to the next question. Yes, sir.
Sure, sir. Because that was a very, very important topic about the neck dissections. Kindly revise it. Let's see this question. So even if without going to the entire question, just look at the image and try to answer. Could be a spot question as well, but yes, as there is a theoretical question, let us talk about it. So here is a 8-year-old boy who comes to the physician with a painless and a smooth mass located in the midline of the neck at the level of the hyoid bone. As noted by the arrow in the given photo, you can see the arrow over here. This palpable midline neck mass was asymptomatic. So very important thing, it was asymptomatic. But due to recent expansion, it has caused difficulty and pain when swallowing. When he swallows or protrudes his tongue, the mass moves superiorly. That is a very, very important point. I hope if you have the basics in your hand, the answer would have been clear by now. So what is the most likely diagnosis? So mass is asymptomatic, it is midline in neck, it is recent expansion that has led to this problems on pain when swallowing. And when you protrude the tongue out, the mass also elevates. So I hope we know the answer, but looking at the options, enlarged deep cervical lymph node is one of the options. Thyroid nodule, branchial cyst, and thyroglossal duct cyst. So I hope there should not be much confusion in this question, and the answer for this question, I hope you all will agree, is the option number D, the last option, the thyroglossal duct cyst. Because of the being asymptomatic, connect to the tongue, and the picture over here showing the arrow, the midline, location, everything. You look at the other options, like the deep cervical lymph node, I mean, they don't elevate well, protrude the tongue, and they are not asymptomatic. Always something must have caused this lymph node to be enlarged. Thyroid nodule, again, if it's a thyroid nodule, there has to be some symptoms. There has to be increase of hormones or decrease, or could be any goiter, could be whatever it is, but has to be some symptoms around it. And again, there's other things. And branchial cyst, again, the location of branchial cyst. Branchial cyst, branchial arches, a very, very high topic. Always remember the branchial cyst location is somewhere in the near the anterior border of the SCM. Near the anterior border of the sternocleidomastoid is where you have the branchial cyst. Near the anterior border of sternocleidomastoid, that's the location. It is also lying laterally. The second thing, it has nothing to do with the protrusion of the tongue. Now, why it is thyroglossal duct cyst? Because that is directly related to the embryology of the thyroid gland. Now, we all should know that if we look at the tongue over here, let me show you the tongue. The thyroglossal duct actually rises from this junction of the anterior and the posterior part of the tongue. Between them, you have a foramen cecum, junction of anterior 2/3, posterior 1/3, right? Thyroglossal duct starts their journey from there, and then they come down. As you can see over here, they're coming down. They go along the hide, and they finally settle down somewhere in the location where you have the actual final location of the thyroid gland, that is in front of the thyroid cartilages and cricoid, and thus that's the location. Now, obviously, you have this isthmus in the center. You have the pyramidal lobe over there, but remember that's embryologically it is connected to the tongue. So, if, along the root, there can be some cystic development. And normally, it is seen around the hyoid bone. Most commonly, it is said to be around the lower part of hyoid, that is a subhyoid location. And as the duct is connected to the tongue, obviously, if you protrude the tongue out, the duct will be stretched above or superiorly, and there will be elevation of the thyroglossal duct cyst. As it is not secreting any hormones, the case over here is asymptomatic. But obviously, there is a recent expansion. It could obviously have a mass expansion. It can be compressing on the nearby structures. And as the nearby structure is your esophagus or pharynx, obviously there will be difficulty in swallowing. That's the whole picture about this cyst over here. And the question which is lying in the 4 options, I hope you can very well differentiate, rule out the options. So there are 2 methods. Either you know the answer. In this question, you know the answer, or you know which is not the answer. So both ways you can reach out the question. That was the embryo and the anatomical part of it, not explaining you the entire anatomy of the thyroid gland. That is not needed over here, but the little bit of embryology over here. So thyroid, and also remember the ectopic thyroids. There's the lingual thyroid could be there where the duct or the journey started, but it never went down. There can be thyroid swelling behind the, or you can say in the posterior part of the tongue. It could be lingual thyroid. They can be ectopic. These things can be ectopic. That was a little bit of embryological aspect of it. Now I will request sir to add some of our surgical knowledge to this entire scenario.
So when we talk about this question, students, one very important thing that sir has already discussed, and this question itself says that whenever you have a patient with the midline neck swelling, you know that since they are included in the pretracheal fascia, whenever there is any movement of deglutition, the thyroid swellings will also move and the other things will move. So thyroglossal duct cyst versus thyroid swelling, both will move. But when we talk about the movement with protrusion of tongue, this will be seen only in this case. And why? Because this is connected to the base of the tongue or foramen cecum. There is also something known as tugging phenomena. What is this tugging phenomena? Remember students, it like tug of war. So whenever you talk about tug of war, there are 2 parties or 2 groups which are holding the rope firmly, and one is applying the pressure, another one is applying the counter pressure. So if you hold this cyst and ask the patient to take out the tongue, you will feel that resistance because of this attachment. So this is what is tugging phenomena, and again these things are clinically very important. Now the question is, sir, okay, there is something which is known as thyroglossal duct cyst. So why this thyroglossal duct cyst developed? Answer is because of the failed what students? Regression. Do you know, we always have to understand there is a deadline for everything. Like you have deadline for exams, you have to fill the form. If you are willing to fill the form, but beyond the deadline it is not possible because the windows have been closed. Similarly, there is a time when you have to submit the blueprint of majority of the things, and I hope that 8th week of intrauterine life is that blueprint. Whatever is there beyond this will always persist in a newborn also. So remember, failed regression of vitellointestinal duct results in a Meckel's, and that is again not after 10 weeks, it is after 8 weeks. Same way, persistence of, you can say, thyroglossal duct beyond 8th week of life will result in a persistent thyroglossal duct. Students, now you will say there are a lot of structures which are persistent, but why was the cystic, you can say, formation here? So you need to understand that they are lined by special cells which are pseudo-stratified columnar epithelium, and columnar epitheliums have tubules, and tubules will constantly keep on secreting something serous or mucinous, and ultimately at the time of the birth you might not be able to see the swelling, but slowly this will distend itself into something which is known as a cyst. So cystic transformation actually is visualized or presenting clinically at the level of 2nd or the 3rd decade. This is what is very important. Now this is just like a balloon. So if you are blowing a balloon in front of your friend, so you are blowing, you are increasing the size, blowing more air, what will happen? Either your friend will get agitated and put a pin, it will rupture, or itself it will. So rupture is the fate of this. So it has to rupture. Either you are tempted and you do iatrogenic rupture, and how you can do iatrogenic rupture? But you were tempted, you never knew, your eyes will never say what your brain what your brain doesn't know, and you tempted, you thought it is a thyroid and you did FNAC, and that was that. or it may be, if you never did that, it may be a spontaneous rupture. Now you will say, sir, there are a lot of structures which rupture, lot of cysts will rupture, and they should actually regress in size, or they should collapse. Now this is just like an active volcano. So after rupture, first of all, for 2-3 weeks, patient will be comfortable. Patient say, doctor, you are great and this is done. Then after 2-3 weeks, the patient will say, sir, something is secreting out. Why, students? These columnar cells are still there. They will keep on activating themselves. So every time the granulation plug forms, after 2-3 weeks, again there is intermittent secretion, intermittent discharge, and after a few days there will be epithelialization of this tract, and this is where the formation of fistula happens. So remember, cyst is congenital, but fistula is always acquired. This is what is very important point. So why the cyst? Persistent thyroglossal duct converted into a cyst and cyst into a fistula. This is in front of you. The next very important thing is that what is the management for these patients? So remember, this is hyoid. So central body of the hyoid is most of the time where infrahyoid location is there. So en bloc cystectomy. What are you going to go for? En bloc cystectomy. What do you mean by en bloc cystectomy? It means the block of tissue around that. So what is the block of tissue, students? It is very simple. You are going to go for removal of the hyoid along with the central part, or you can say removal of cyst along with the central part of the hyoid, and this is what is known as what, student? Cyst trunk. Remember, INI-CET every year, I think, sir, they ask a question on this thyroglossal duct cyst. So cyst trunk surgery. Now there is something which is very important for you people. What is that? Cyst trunk surgery. Where else you get to see? Answer is for lymphatic system. So in lymphatic system, we have a limb reduction surgery where we go for en bloc excision of soft tissue along with the skin, that extra skin that you have, and this is also again a surgery done by cyst trunk. So there was a question asked on chronic lymphedema, and there was a question that which of the following is not a limb reduction surgery. In option 1 was cyst trunk, 1 was Charles, 1 was Thompson, and 1 was Nebulovics. So many people said, many examiners, or many, you can say, people were answering that okay, cyst trunk is a surgery done for thyroid. No, cyst trunk is a very famous surgeon for 2 surgeries. 1 is for thyroid and 1 is for lymphedema. The answer was Nebulovics, because it is nothing but lymph node to a vein bypass, which is practically impossible, and that is why for lymphedema also we do palliative or cosmetic surgeries, that is limb reduction surgeries. So I think this is all for the day, and I hope you enjoyed. We will be getting more such series for you, and you already have this dedicated series with other teachers also. A lot of them are integrating, and students who are really working very hard. So do subscribe to our channel, do share the links of the class with your near and dear ones, and do check our app which is available on Play Store as well as in the App Store. We are getting something great for you. The content is crisp. We have decided to give you a lot of strategies, lot of levels of question, the basic orientation, the clinical vignettes, so level 1, level 2, level 3. So right from the basic students up to the toppers, we are going to, for the toppers who have a knowledge or who have already prepared, we are going to do that icing phenomena for you. So we all faculties here at Allen Next are working day and night for you to create something magical content and handhold you to your journey from being from MBBS doctor to being a specialist. So till then, bye-bye.
Bye-bye, guys.